Thank you, Barry. And thank you so much for inviting me, and I apologize for not being able to gather the appropriate funding to be there in time on a short notice. But I do hope that this is the first step in our collaboration, that we will have other opportunities to meet in person. I'm going to try to be brief because I'm standing between you and the lunch. But I will tell you briefly about evidence-based methodologies and how they could potentially be useful for some of the work that Hajime and others are working with OECD on test methods assessment. So with that, so I will briefly tell you about the evidence-based methodologies and their origin in history and what they've done in medicine. Unfortunately, I don't see you. I usually ask people, Barry, maybe you could help me to sort of engage the audience, asking how many people have heard about evidence-based methodologies or practices. Can you tell me if there are any hands raised? I can't hear anyway. Okay.
Yeah, I had it muted. Most people, it's a new topic for them. We just took a show of hands. I was muted.
Okay. Were there any people who know about evidence-based methods or systematic reviews?
Yeah, there's a couple of people who raised their hands.
Out of how many?
Minority. Just a couple of people raised their hands.
Okay. 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 So yeah, that's what I expected, and that's normal for scientists in general. If you are not a physician, you usually haven't heard about this methodology. So that's what we're trying to change. So what is EBTC? So evidence-based toxicology collaboration was formed by Thomas Hartung, who most of you know, at Johns Hopkins officially in 2011. And what we're trying to do is to bring together the international community of science, regulatory, and industry professionals to bring the evidence-based methodologies from medicine to toxicology. Okay. And this is a disclosure about funding, and we are in Baltimore at Johns Hopkins Bloomberg School of Public Health. So what is evidence-based methodology? So when I tell my friends, that this is what I'm doing right now, I say, well, you're a scientist. Haven't you always done evidence-based science? And what have you been doing before, right? So I have to explain to them that what it is it's really a framework that has developed into the standard of quality of practice in medicine over the last 30 years. So the major principles of evidence-based medicine are transparency, consistency, statistical rigor, minimization of risk of bias, and a very systematic framework of stepwise approach to assessing the evidence. And originally it was developed for comparing medical treatments, comparing one medicine to another for treating particular conditions, comparing a medicine to a placebo. So when Archie Cochrane in the UK started doing it in the 50s, he found that actually the randomized clinical trials were a rarity. There were all kinds of study designs, and it was virtually impossible in some cases to compare apples to apples. And that was the origin of this study. And if you are in test methods assessment and in chemical risk assessment, you probably can concur that there are some things that we could improve in the quality of our science and the way we're reporting the studies, the way we manage the data. So the presentation before was about the quality management and the data streams. That's all very important, and that all feeds into what I'm going to talk about. And again, apologies for it's really late here in Boston, and I may be trying to keep myself awake. So why systematic review? So the systematic reviews is a principal tool of evidence-based medicine. And why is systematic, and what is the difference between narrative review and systematic review? We've all obviously heard of narrative reviews, and many of us have written them and read them. So the problem with the major differences between the narrative review and systematic review are outlined in this slide. So first of all, the research question is usually not explicitly stated in narrative reviews, whereas in systematic reviews, it's a very precise PECO question. So you may say, what's PECO question? So PECO stands for population, exposure, control, and outcomes. So every question in systematic review has to address specific population, whether it's particular diseased population, people with men, women, certain age, or it's, in our case, in toxicology world, it's a particular animal strain, or it's a cell type, or whatever. The exposure, what were they exposed to? So it's usually chemicals, drugs, and such things. The control, there has to be a control, right? So it's either this population unexposed or exposed to another agent. And outcomes, what did we measure? So every systematic review has this, has to have these components. The protocol, so usually the published protocol with explicit statement about inclusion and exclusion criteria, search strategy, and the outcomes being measured, and the results, and how we are going to analyze the study. That's usually published before the study is even initiated. And that's not the standard in toxicology. You probably would concur to that. If anybody disagrees with me, and if this is done differently, I'm happy to discuss. So the study selection is done very systematically also. That's usually not described in narrative reviews. The quality assessment of the studies is usually also not done. So these are the major differences. And now that I've been in this at this job for 3 years, now I very quickly can tell what's a narrative review and what's a systematic review. There are huge differences in how they're written. And a major difference between them is that the narrative review is a subjective opinion of one or a few authors, where they go and select the studies that they like or find interesting and write review about it, right? With in systematic review, you actually go out of your way and exhaustively try to find all of the evidence that's available to answer this specific question, and then exhaustively apply inclusion-exclusion criteria to find your answer. So here's a little disclaimer. So the systematic reviews actually are not a solution for every assessment and for every study. They're best suited for data-rich questions where there's a lot of literature, right? So the example where it's not suitable is proprietary compounds, drug candidates, or tests with little or no publicly published data. When the data is all proprietary in pharmaceutical companies and such things, it's very difficult to do systematic review. So these are the principles of Cochrane Collaboration, where most of this work in the field of medicine is done. And you can go on Cochrane.org and read those, but they're very, these are the principles by which EBTC, my organization, is trying to live by. So it's transparency, collaboration, involving, supporting, and training people. We have a number of volunteers that we trained in doing systematic reviews, collaborating with everybody around the world, ensuring the quality by a rigorous application of the methodology, and enabling wide participation in our work. So the impact of Cochrane Collaboration on clinical medicine is really huge. It's really hard to overestimate. So again, as I said, the randomized clinical trials were really not a standard when this work was started in the 50s. Now they're standard in practice. Moreover, there was a huge effect on the quality of the clinical research that was being done, and on the reporting in the literature, such as structured abstracts. When you look at the clinical randomized clinical trials, any clinical literature report, you usually see the abstract pretty much written in a PECO format, where you have the model that people are studying, what drugs they were exposed to, what levels of drugs, what doses, how many patients, and what were the outcomes and the results, right? So this is how the studies themselves are written up, and that's how the systematic reviews in clinical medicine also are written up. So, but remember that it took 30 years to get to this point, to the point where it's accepted and it's standard. So the steps in evidence-based policy basically is identify the problem, formulate a question, write a protocol, publish the protocol, make it public, search for evidence, appraise the evidence. Usually the appraisal is done by 2 reviewers per paper, and integrate the evidence, do the qualitative or quantitative analysis. And then, so this is where the systematic review ends. And what happens in medicine is there is evidence-based practice where in the US and UK, and I think in most other Western countries, the practice of medicine is done according to evidence-based principles. So this is applied to practice on insurance level, on a country level, depending on how the health insurance is being paid in your country. So what about the other fields? So the regulators in environmental protection and food are actually actively using systematic review. So EFSA, European Food Safety Authority, was a pioneer in application of systematic review here. So they have their own guidance on systematic application of systematic review methodology to food and feed ingredients to support decision. The EPA has started investigating it a few years back, and we're lucky to have Chris Tsaioun on our advisory board, who is a pioneer of systematic review, who was working at NIHS, developing their own guidance on conducting systematic reviews, and now she's at EPA. There's other agencies that are actively evaluating systematic reviews, so pretty much going in step after EPA, such as FDA, Food and Nutrition Division, and OECD, who is also, there's Anne Gurmilan has just joined our board of EBTC, and we're helping them to put together the workshop on using existing data, which is planned for October this year, which is going to feature the EPA, Chris Tsaioun again, and Rob DeVries from Circle. So the Institute of Medicine wrote this Bible of systematic reviews, which is called Finding What Works in Healthcare. And it's a big document. It has 21 standards and 81 elements of performance. So if you want to dig in and really find out how it's done, I highly recommend to read this. So where do the systematic reviews stand in terms of the sort of a pyramid of evidence, right? So we have at the bottom of the pyramid, we have case reports, opinion papers, and letters and such things, which may or may not be reproducible. We have animal trials and in vitro studies. The reason they are here at the bottom right now is because of the indirectness, right? We are predicting the human effects from animals or from in vitro studies. And I think there is an opportunity to bring them closer to randomized clinical trials. And this is all the work that we're all doing together. So then there's cross-sectional studies, case control, cohort studies. So these are all epidemiological observational studies, right? And finally, there is randomized control trials, which is the highest evidence on individual study level. And the meta-analysis and systematic reviews are at the top of that pyramid. So the problem with just strictly applying this this concept, this framework to toxicology, is that we are frequently answering very different questions, and we are also dealing with very diverse populations, right? So it's a randomized clinical trials which are done in humans versus our data sets, which have laboratory animals, in vitro studies, epidemiological studies. Now we have modeled evidence. So all this stuff needs tools for doing this work, for assessing this evidence, which didn't exist, which are starting to emerge, but they still, by and large, they don't exist. So the tools that are starting to appear, so the NTP OHAT has their own handbook on conducting systematic reviews, and the risk of bias tool. They have done applied these tools in a few assessments, which you can see here, and continuing work in this area. So they were one of the pioneers here. So the standard systematic review process is outlined here. So it starts on the top. So you conduct a search after you have done your question formulation and protocol. You conduct your search in as wide as possible in relevant databases, PubMed, but not only PubMed, but also Biosis and other Agricola and other databases that may be relevant. In many cases, we search gray literature as well for white papers and such things. The records are screened usually by two people on title and abstract level, and then on the full text level. Right? For each exclusion, there has to be a reason that's written in the protocol, and that's one of the exclusion criteria. Then studies are, then the data is extracted from those papers, and studies are included for qualitative and, if possible, quantitative meta-analysis. So what can it do for the work that we're doing? Most of us are doing here, validation of new test methods, right? So we know that there are some limitations and some struggles in the approaches that we're doing now. One of them is relative lack of harmonization. There is a lot of time and resources that are needed for validation of each individual method. By the time they're validated, there's other newer methods that are coming up that are more efficient and more predictive. So there's a sort of constant catch-up work that we're doing. Moreover, some of them are still focusing on predicting of the status quo test, which are not necessarily relevant to the target species and to the main question. So the advantages of using systematic review for some of this is using historical published data, so there is efficiency there, relying on the proven framework, and it can focus on mechanistic relevance. It depends on the question that you ask. It doesn't have to focus only on analytical precision. So I'm not going to talk a lot about this because we just heard the presentation of Fujima. There are many challenges in validation. It's a true bottleneck for getting the wider use for in vitro methods. So how can systematic review assist in this, right? So this is our proof of principle. Again, the PECO question: population exposure and control and outcomes. And this is one of the working groups that's addressing this question. So how well do the EPA ToxCast in vitro tests predict the liver outcomes in animal tests and in humans, right? And we have a data set of 10 drugs with and without drug-induced liver injury from EPA ToxCast, and we're using systematic review to get the animal and human data, right? So this is the schematic of this project. So we have approved drugs with and without drug-induced liver injury, and we have 3 streams of evidence. One is the data set that we already have, which is publicly available. It's EPA ToxCast data. Another stream is a systematic literature review of animal studies, and we have a stream 3, which is human adverse events database. And the randomized control trials, right? And it's a big project with a lot of contributors, and we have a great partnership with Douglas Connect, Barry's group. So Ahmed and Maya are managing 2 evidence streams here. And Gunn, Vist, and Hubert Driven from Norwegian Institute of Public Health are doing the systematic review part. So this is how many folks we have in the group right now. So this is where we are with the stream 1. So this is just, I have the dates there just to show you how long it takes. But it took actually less time than we thought, because this is already second systematic review that we're doing, and we already had the software, and we sort of knew what we were doing. But it takes some time. So this is the project timeline. So we officially started, the working group was formed in February of last year. So the challenges, so the manual process to search, review, and extract data. Then finally, we have to somehow integrate the AC50 or points of departure from in vitro studies, low L's, no L's from animal studies, adverse event frequencies in clinical trials or in pharmacovigilance data, and connect perhaps these diverse outcomes to AOPs. There is another idea that we're working on, is potentially to create a systematic map to assemble into a systematic AOP. Right? So obstacles to implementing the EBT. So it's a duration and expense, right? So it takes about 2 years. That's if you have the tools. And preclinical literature reporting quality. So there's missing data, there's incomplete methodologies, lack of primary data. That's just a few. Lack of consistent terminology and outcome reporting. So this is an ontology project that Barry has been involved in for a long time, and you all are working on some of the aspects there. Variety of study designs. So that's immediately you wouldn't be able to do meta-analysis for many of these studies. So all these are limitations. So can artificial intelligence actually help? So there is a thinking in the field that yes, that the answer is yes. So here we have the steps of the systematic review that you already know by heart probably, because I keep repeating them. So and these are in red. We have the steps where we really have the AI opportunity, which is not addressed right now. So the question formulation is partially addressed. There is a tool that Tsaioun has developed that's really helpful. The systematic map, the search, automating the search, automating the data extraction, the risk of bias tool. There is a tool developed at NIH, HOC, and there are some tools on doing meta-analysis. But what's the bigger problem is that you have to keep switching from tool to tool as you go to different steps. And of course, there could be errors if you do this so many times. So developing one system and one for the whole process, I think, is really important. So what is the end goal? So I think what I envision is that this PECO question could be entered into an AI-powered browser, and you will have answer to the systematic review with to this question through the systematic process and meta-analysis done for you in real time. So that's the dream. So that's where the humans would formulate the question. They would, and then the machine would do the rest. They would do literature search, review, apply inclusion-exclusion criteria, simulate the two reviewers. And then what's really cool, I think, and that's I know a couple of groups already working on it, you can have continuous update of this, automatic update. And this will create the living systematic review. So if there are more studies that will be published in the coming years answering the same question, you will just automatically be added to that meta-analysis. So I think this is really exciting time. So we have a few projects that are going on in this area on the systematic maps, collaboration with Lancaster University, where we are looking for AI collaborators. We are establishing a framework for evidence integration with some meetings coming up. The critical appraisal tool for in vitro studies group that some of you are involved in. The criteria for structured abstracts in non-clinical literature. We're working on the journal editors workshop and other things. So these are some of the groups that we have started and projects we're working on. And they're all open, completely open, non-proprietary. You're welcome to join any of them. You just get in touch with me. So this is how we're structured. So we have board of trustees, we have and scientific advisory council, and we do our work through working groups, organizing the working groups. And this is our website. This is our board of trustees. So we're trying to achieve the balance between the regulators, academics, and industry. So as you can see, this is pretty well split. These are some of our stakeholders and members. Again, they span preclinical and clinical space, and include both decision-making body of evidence folks and the people who care about the study level quality and doing systematic reviews in particular areas of preclinical science. So this is where we are, all the stakeholders, and it's mostly transatlantic collaboration. So we have a lot of the stakeholders in Europe, one in Turkey, one in Brazil. And as you can see, we have nobody in Japan, nobody in Korea. So I think this is it's important to have everybody involved in this initiative. So again, we have I think we're doing pretty well with the sector balance here, and we definitely are missing you guys. We're missing Japan, so we would like to collaborate. So this is our small staff, and I'd like to acknowledge all of the work of my colleagues here, as well as a group of students that have done some of the work on the Tox21 project. And if you have any questions, please get in touch. And Barry also knows how to get in touch with me. Thank you so much.